Hello, everyone. It's so good to see you all. So many familiar faces. Um, it's my pleasure to introduce Dr. Bryan Haugen. Dr. Haugen is an endocrinologist at the University of Colorado, Denver, in Aurora, Colorado, just down the street. Dr. Haugen is a professor of medicine and pathology, as well as head of the Division of Endocrinology, Metabolism, and Diabetes, and chair of the Endocrine Neoplasms Research. All right. Dr. Haugen's clinical and research interests focus on thyroid cancer, including molecular therapeutic targets. And Dr. Haugen is a past president of the American Thyroid Association and a ThyCa medical advisor, which is very important. Thank you so much.
Great, thank you. So my first disclaimer is having Dr. Maria Cabanillas right here in the room. If there's any questions, we'll have Dr. Cabanillas answer those questions, or I'll defer some of them to her. She knows 100 times more about this than I do. But anyway, what I wanted to talk to you about, or Gary had asked me to talk to you about, was anaplastic thyroid cancer. And I'll talk a little bit about the program at Colorado. I hear they have a very good one at MD Anderson too. So what I wanted to do was, in a way, talk about three different eras. And we did a book chapter for the group book on the thyroid, and we were asked to do anaplastic thyroid cancer together with one of our endocrine colleagues, Dr. Klopper, who's now actually at Veracyte, and then Dr. Madeline Kane, who's one of our medical oncologists. And we kind of looked at the literature, and what you see here, starting with, is what I call kind of the pre-taxane era. And before these cytotoxic chemotherapies called taxanes were available. And you can see the main thing in the middle there, you see therapy, it all says varied. All these patients, this is collected from different just groups, single centers, things like that. The type of therapy they got varied, and it was very ineffective. And you can see the median survival was in the range of 3 to 5 months. So it's very, very low. Then in the taxane era, there is some improvement. And we actually participated with Dr. Ken Ain doing this kind of funny study with paclitaxel. It was an IV infusion over like 72 hours. We'd bring people into our hospital and give them this. And there did seem to be some benefit, although you see there, the top one, only 5.8 month average survival from diagnosis and getting the therapy. But you can see lower, and I'll show you a little bit more on some studies, but the one below it from the Mayo Clinic, it was 60 months. So that really was a move forward. Now, what they did was use a lot of cytotoxic chemotherapy and radiation. And there was a lot of toxicity. And then again, some other ones though, different ones down below, one out of Japan, still only a 3-month average survival. So it still was pretty bad. Then what I would say is we moved into the era, and I'm sure there probably are some other studies before this, but I'll just use this as an example, about 2013, into the era of using targeted therapies. And this is using a drug called pazopanib. That is what's called a multi-kinase inhibitor, and I'll just show something on the next slide, together with the cytotoxic chemotherapy paclitaxel. And they just show an example here of a patient who had, and you see these lung metastases, and a lot of anaplastic cancer will look a little bit more aggressive like this rather than the little dots we see with differentiated thyroid cancer. But this patient really had a good response, and they did some really nice research to try to understand how this is working. And interestingly, what it did is it forced the cells, their chromosomes just went nuts and they died. So it was what's called mitotic catastrophe in this. And so this is kind of what I would say is one of the early uses of targeted therapy in anaplastic thyroid cancer. So Dr. Cabanillas and colleagues, I use this a lot. This is a pretty picture. Is in the middle of this is the cancer cell, because we're always thinking of the cancer cell. But really, what we want to think about is the whole microenvironment. And again, this is really, you think it looks crazy and everything up there. This is oversimplification, right? This is what we think about all the time. And on the right-hand side of the cell, you see what's called an endothelial cell. Those are the cells that kind of form new blood vessels. And on the left-hand side, you see what's called a T cell representing the immune system, although the immune system has many different types of cells. But the reason I kind of use this is you see the red arrows are pointing to this pazopanib. And it hits something called VEGF-R, and that has a lot to do with vascular supply and blood flow. It also hits FGFR, fibroblast growth factor receptor, which a lot of cancers have these receptors, and that helps them to grow. And so it targets that. It also targets what's called platelet-derived growth factor receptor, PDGFR. And so this is the reason these are called multi-kinase inhibitors. And you'll see the most common one we use in differentiated cancer that needs chemotherapy is lenvatinib. It's kind of down at the bottom of a lot of those. It also is a multi-kinase inhibitor. And I'll show you some data on it being now used in anaplastic thyroid cancer. So inside the thyroid cell, there's what I call the gas pedal. And that's these pathways that normally what they're doing is you can see the receptors on the outside, the different colored receptors, they're waiting for signals to tell them to maybe grow, divide, or stop. Signal comes, signal goes. A lot of these tumors, what they do is they get mutations, either in those receptors, they get changes, RET is an example. In medullary thyroid cancer, they get point mutations that turn it on. In differentiated and even in anaplastic, they can have rearrangements that make it overactive. And so that's what we see there. And then they go down these pathways. One is called the MAP kinase pathway, and another one is called the PI3 kinase pathway. And they're just gas pedals. And they're constantly then on in these tumors. And the other problem with anaplastic usually is it loses some sort of a break, most commonly a protein called P53. And that'll basically have the gas pedal on full and the brake off. And these things, as many of you know personally, these things can be very aggressive and grow very fast. Then another thing I'll point out from this slide, because we'll talk about it a little bit on that lower left-hand side, is again that T cell trying to recognize and kill the cancer cell. And what the cancer cell can do, these are what are called checkpoints. And so the most common one you'll hear about is one called PD1, programmed death 1. And then the tumor cell or other cells can have what's called the ligand for that, PDL1. And when those two get together, it's kind of a signal to say, leave me alone, don't kill me. And so what you can do is use antibodies. Again, a common one is pembrolizumab, another one is nivolumab. There's all sorts of ones, and I'll show you an example of even a different one. You can use those to sort of break that tolerance and try to get the tumor, the immune system to recognize and kill the tumor. Unfortunately, these alone probably are not enough, so we're using them in combinations as we're going forward. So that I just wanted to give you that's the background for what a lot of these studies do. Thank you, Dr. Cabanillas, for a wonderful picture. And it's a great slide. So this is an example. And again, I'm not going to go through all the literature, just show you some more recent examples. This is one using PD-1 blockade. So that's that thing I just showed you in anaplastic. And this drug is called spartalizumab. And the other thing is somebody asked me in another session, there's some drugs that are called IBs and some drugs that are called ABs. The ones that are called IBs are usually the small molecule inhibitors of these pathways. And the ones that are called ABs are antibodies. So if they're going to give you an AB, then you know it's going to be an infusion of an antibody. And the IBs like lenvatinib or pazopanib, those are the small molecule inhibitors. Anyway, what this study showed was that there was some improvement overall response rate, which again, I think many of you get probably familiar with that sort of stuff if you come to these talks. What that means is you either have a partial response that the tumor shrinks by more than 30%, or you have a complete response where the tumor goes away and you can't see it with imaging. Okay, and that's what's called an overall response rate. And that was 19%, pretty good, but not great. And then complete response going away was 7%, 3 of the patients. But one thing you'll see here is what they do is they look at the tumor and say, does it have that ligand, PDL1? If they do have it, they seem to respond better, especially if it's over 1%, is what the two upper lines are. The lower line is if it's below 1%, but unfortunately, it's not a perfect marker. So we can't use it to say, oh yeah, you're going to respond or you're not going to respond, but it does help us a little bit to look at those markers. And also those markers and some other things we do help get it paid for by insurance, because in certain patients with certain tumors, if it meets those criteria, then the insurance will cover it. So here's an example of a study using 2 drugs, lenvatinib, that common multi-kinase inhibitor, and pembrolizumab, another PD-1 antibody. And this was a study out of Germany. And what was interesting here, it's a small number of patients, but you see those CRs. There are 4 complete responses there, and those are in patients with anaplastic thyroid cancer. And so a lot of us, what we do is if a patient is not responding to other therapies or doesn't have the BRAF inhibitor, the BRAF mutation, which I'll come to, we consider this type of therapy in some of those patients. We need bigger studies, and bigger studies are being done. And then what a second thing we look for is tumor mutation burden. So the mutations in the DNA of the tumor. again, it's both a biological and an insurance thing. If your tumor mutation burden is greater than 10, the insurance companies a lot of times will cover the drug. If it's less than 10, they may not. And you can see, though, what's interesting here is you think, well, the more tumor mutations you have, the more what are called neoantigens, which means it's kind of a new change, a mutation, and it's presented to the immune system as an antigen, and the immune system can attack it. The person who had the best, longest response had a very high tumor mutation burden. The person who had the second best response had the lowest tumor mutation burden. So again, it's not a perfect, but it's a helpful marker that we use in patients. And then here's the median progression-free survival of about 17 to 18 months, and the overall survival about 19 months. So much better than that 2 to 3 month, but not perfect, right? But these are therapies that are now coming up that we're using. The one I think many of you are familiar with, and especially those patients who have anaplastic thyroid cancer and had a BRAF mutation, is this study here, which a number of people contribute. This was a larger study outside of thyroid cancer. Dr. Cabanillas and her group participated in this. And this, I was always amazed, this number, there's now, I think 33 was the second publication, 33 patients. This was 15 patients, 16 patients. And it got FDA approved based on this, because this was really impressive. And I must admit, I don't know what Dr. Cabanillas thought, but I would have looked at this and said, that's not going to, I don't think it's going to work. I think they're no longer dependent on that gas pedal. I think they got a whole bunch of other reasons to be bad cancers. And they do, but they're still very dependent on that pathway. And so this shows people getting treated in the MAP kinase pathway. There's RAS, RAF, and MEK, and then ERK. But what there are is RAF inhibitors like dabrafenib, remember IB, small molecule, and then trametinib is a MEK inhibitor just downstream of that. You hit that pathway hard, these people do very well. The thing up top is called a waterfall plot, and this just basically shows tumor shrinkage. And the person in the blue bar on the far right was a complete response. Couldn't see tumor anymore. Now, one person on the far left, their best response was some growth. So not, again, people respond somewhat differently, and this just then CAT scan shows some examples. The other thing I do like is I'm a fan kind of these what are called waterfall plots. How long did they respond? And so this shows up top is a patient who responded a very long time. This is in weeks, and we're out to like 120 weeks. And they were still on therapy, still hadn't progressed. Pretty impressive. And we now know there's even some longer responses, but you can see that there's variation. And so what we're trying to do now is do what are called correlative studies to basically say, is there something in the blood or something in the tumor that can give us a better idea who's going to respond to what drug? And we're getting there, but I think we're still working on that. And then, so the last thing I kind of wanted to talk about with this before I get to this complex algorithm that many of you may have seen in the American Thyroid Association guidelines. But this again is a nice study out of MD Anderson, which is why Dr. Cabanillas should be giving this talk and not me. But Dr. Mark Zaffareo and colleagues, and Dr. Zaffareo is here today. We're doing this. This is what's called neoadjuvant therapy. So here, this is where you're giving it before surgery to try to make the surgery safer and complete. You want to remove all the tumor, would like to leave important structures like the voice box, like the blood vessels, things like that, the airway, the esophagus. And I'll just, an example, the upper right, you can see there on the left-hand side of it, that double picture, patient number 1. You see their brain, this is an FDG PET scan. You see their brains light up because they like to eat glucose, they exclusively eat glucose. But that mass below the brain is a whole bunch of tumor in that patient's upper and lower neck all over the place. That is not surgically resectable. And then in the past, we would try to maybe do radiation and chemotherapy on those patients to see if we could help. This patient was treated with dabrafenib and trametinib. They had a BRAF mutation. And you can see the one right next to it, to the right of it, they still have tumor, but now that's much more resectable. And they can take the tumor out with surgery. So this is called neoadjuvant therapy. And this is and interestingly, we've not found good ones yet for differentiated thyroid cancer that is this impressive, but there's some really impressive effects in anaplastic thyroid cancer. So the guidelines, I don't know how many of you are familiar with these, the 2021 guidelines that came out, that again, Dr. Cabanillas was part of the guidelines. Here, Marie, I'll give you the microphone. But anyway, this is complicated, right? But what we do is you look at 3, and as many of you know, anaplastic thyroid cancer is only stage 4. You have a 5 millimeter anaplastic in your thyroid, you're stage 4. That's what's called a 4A because it's confined to your thyroid. If it's outside the thyroid in the neck, that's a 4B. And if it's distant metastatic disease, that's a 4C. Okay. So you can see up there on the upper left-hand side, they say 4A. What should we do with 4A? We definitely should do surgery in those patients. Big thing to do is stage them appropriately, obviously, make sure it's not anywhere else. But what you can do is focus on surgery on those patients. And the goal is to get a complete resection. Again, to do it completely and safely. Stage 4B, a lot of times will have invasion outside of the thyroid. And so the question is it resectable, safely resectable, to try to get everything out? If the answer is yes, go to surgery. If the answer is no, that's when we start doing our molecular testing. And like many places do, what we have at the University of Colorado is we can get a rapid BRAF test. And what we do is we get an initial read. We don't do the immunohistochemistry. I believe that's what they do at MD Anderson. But we can, within 24 hours, get a preliminary read that usually is accurate, and then they'll give us a formal read of what the BRAF status is. If they have a BRAF mutation, that's when we consider those targeted therapies against BRAF, dabrafenib plus trametinib. If they don't, we look for other mutations that are rarer. For example, a RET rearrangement in anaplastic is maybe in the 5 to 7% range, but it's still enough people, and there are therapies that are actually quite good, selpercatinib and pralsetinib. And so anyway, you can see that, and if they don't have those other mutations in that, then again, what we do is we consider other therapies. Sometimes it is chemotherapy and some radiation if we can't treat it by these other ways. Like I said, what we do with some patients too is use lenvatinib plus a PD-1 antibody, and there's emerging data on that. But in people, we can't use other drugs, but we still use some of those cytotoxic chemotherapies, meaning paclitaxel, docetaxel, what are called platinums, and things like that. But we try to use more of the directed therapies if we can. And so that's kind of a way to look at least stage 4A and 4B. What about 4C? Well, 4C, again, this is, and all of them, I think many of our institutions do. What we do is we get palliative care involved very early because it really helps the patient, think about, okay, what are my values? What are my wishes? What do I want to do? It doesn't say, okay, should we do nothing or do something? Getting palliative care involved helps with pain, helps with eating, helps with a lot of other things that while we're, thinking about the cancer, they can really help, and they think about the whole person very well. So we get them involved in all different anaplastics. Anyway, the question always comes is aggressive care desired? And if we have some patients, we have just widespread disease, their quality of life is terrible, and they just say, I don't want to go through that. What we do is we want to do palliative care, things like hospice. Those are still, and a lot of that is with the patient's wishes and the shared decision making. But again, you can see you do the BRAF mutation, and you can give them those drugs. We look for the other mutations there. You see above the BRAF, if it's no, we look at that PD-L1 expression and tumor mutations to say, can we use some of these checkpoint inhibitors? Again, more and more now, we're not using them just by themselves. We're using them with something else. And at Colorado, what we'll do, if we can't use others, we'll use lenvatinib plus pembrolizumab. And again, you can then see kind of a favorable response to therapy and kind of the ways that we treat these folks. So I think they did it. I think it was a good job. You guys must have been going back and forth, all the different arrows going in every which direction. But overall, if you slowly walk through it, it's actually quite helpful to kind of see the best way to do that. And again, we talk about targeted or lenvatinib plus PD-1. What I do like is there's two recommendations, recommendation 8 and 9. Recommendation 8 is comprehensive disease-specific multidisciplinary input should be obtained before declining goals of care. My feeling is it should be done for all patients quickly. And then the other is obviously the treatment team should include palliative care expertise at every stage of patient management here. And so what we do, we have what's called the rapid anaplastic response team. And again, a number of other institutions have this as well. And then these are just the subspecialties that we have in this team. And probably the most important person is the third from the bottom, the patient care coordinator, because she's the one that helps coordinate this. If one person says, oh, I just heard about a patient with anaplastic, what we do is we alert this, send this out to everybody and say, okay, who can see her within 48 hours? We try to get them seen within 48 hours by all this team, except interventional radiology. We have them there, but we only use them if we're going to We don't get their opinion on what we should do, but we get everybody else's opinion, including palliative care. And we get our molecular core involved and quickly get BRAF testing and then subsequent testing if BRAF is not mutated. But the goal is to get the patient seen and to set a plan within 48 hours. So finally, clinical trials. And I don't know how many of you patients, do you go to the clinicaltrials.gov? Do you know that website? Okay, because here's just an example, and I put up there anaplastic thyroid cancer. And also what's nice is on the left-hand side, you can see lower down, something is checked that is called recruiting. So that means they're actively recruiting. So you can say, okay, you don't want to know the studies maybe that are already fully recruited and are closed, but they're still on the website. Because if you're looking for a study, you wouldn't be able to get into those. So you can look for ones that are recruiting, and then you can see here, they'll give you this nice example, and you can scroll down. The other thing you can see, the very first one, you say, oh, that looks like a good study. It's in Japan. So if you want to go to Japan, you can go to Japan. But, what's going on in the United States? Well, what I did, I looked yesterday just to update it. Anaplastic thyroid cancer, there were 90 studies. 21 of them were actively recruiting. 8 were in the US. So there's a lot outside the US that are on clinicaltrials.gov. And then these are those studies. So you get some interesting drugs. Vudalimab. So that's an antibody like pembrolizumab or nivolumab. But instead of going just for the what's called PD-1 pathway, it hits a second checkpoint pathway called CTLA-4. So it's doubly hitting it. And this is actually, there's great data in melanoma where hitting both of these pathways really is very strong. And so now they're trying this in anaplastic thyroid cancer. Dr. Cabanillas' group is doing dabrafenib, trametinib, and pembrolizumab. So now we're adding D plus T looks good. Now we're adding that immune therapy and to see if that's even better. And this is as a neoadjuvant, again, meaning this is given before then considering surgery in patients who have advanced disease. There's a lenvatinib plus pembrolizumab study for 4B and 4C disease. I see that's 6 I put on there. I don't know my Roman numerals. So it's 4B and 4C disease. There's a selpercatinib neoadjuvant therapy again, so people who have that RET rearrangement, you can use that. There's CAR T cells that go against what's called ICAM1, and that's been in process for a little while, trying to now use the immune system where you take out their T cells, engineer them, and put them back in to attack the cancer. That's still what I would call in its infancy. I must admit, I heard a great talk, once again, by somebody from MD Anderson, talking about NK CAR cells. So these natural killer CAR cells that really look pretty interesting, that the attacking the host is much less with those than it is with these CAR T cells. I just thought that was pretty fascinating. So there's radiation followed by pembrolizumab. So in a way, you're radiating the tumor, probably stirring it up so it's recognized better by the immune system, and then giving the checkpoint inhibitor to get the immune system to kill the cancer. Dabrafenib, trametinib plus another PD-1 inhibitor, cemiplimab, and then dabrafenib, trametinib plus radiation therapy. So there are a number of trials that are actively recruiting and going on now. So we have a lot of therapies, and we have really some nice studies that are going on. 10, 15 years ago, we did not have this. And I must admit, we were talking about this. We would have maybe 3 or 4 people in a room talking about anaplastic thyroid cancer. I think because survival is getting better in a lot of people, we're getting more and more people who now are coming to these. So I think this is really good, and there's a lot more studies on the way. So I looked here, and one theme I see here obviously is immunotherapy. So this is moving into the immunotherapy space. And the other is into the neoadjuvant space. Once again, of saying, let's do some sort of systemic therapy. And then what we're going to do is see if now they're surgically resectable with that. And so like I said, that's kind of all I have for specific talks. Obviously, up at the top here by the mountains, this is a nice mountain picture here, the Maroon Bells up by Snowmass and Aspen. But obviously, the University of Colorado folks, especially highlighted Dr. Dan Bowles, Dr. Madeline Kane, and Jen Reno, a PA who works with them. This is our medical oncology colleagues that we work with there. I call it my training wheels. I go to their clinic and I do all this stuff, but I do it with them. And then we got our surgeons and a whole bunch of other people that are involved here. But anyway, what I want to do is then open it up for questions. And again, I may ask Dr. Cabanillas to chime in too. I saw her taking a lot of notes. Sorry to pick on you, Marie.
I was going to ask, there's lots of talk about the work that you guys do on the BRAF positive front, but what about the BRAF negative? Or those of us that don't have that one or may have others? That's
Yeah, so again, a very good question. About 40% of patients with anaplastic thyroid cancer will have the BRAF mutation, but 60% don't. And that's where one thing we do is we look for those other, especially those rearrangements. And the common ones we look for are one called RET, NTRK, and ALK. And so we'll look for those because there we can try some therapies that are directed against those if they have that. The other thing we do is we look and see, is the tumor mutation burden high or is that PD-L1 high? You can use the immune therapy for that. Even if it's not, some of those patients, what we tend to do, again, what we've done more and more at Colorado, and I'll let Maria talk about MD Anderson, but what we'll do for some of those folks is use that lenvatinib pembrolizumab combination. And some folks, we still use things like paclitaxel, radiation, plus minus some other agents. So there are a number of things we can do outside of that. But what we try to do is work through the targeted therapy first, and then look to see if somebody, the other thing is getting on a clinical trial. You're on a clinical trial. Okay. Yep. Because that's another, yeah. And like I said, about 60% of people don't have a BRAF mutation. So it's actually a small majority that don't have it, but they might have those other rearrangements. They might have, like you said, you didn't have any of that stuff. So then we do consider some of these other multi-kinase inhibitors with immune therapies, the standard cytotoxic chemotherapy with other kind of treatments as well. I don't know, Maria, do you have any other comments you want to make on that? Here, I'll give you a microphone.
Yeah, in general, I think it's the same. We try and combine an immunotherapy with a targeted therapy that's kind of a broad targeted therapy, not towards one gene, like lenvatinib, pembrolizumab. But there are new drugs that are coming on, like for RAS, targeting RAS mutations, which is about a quarter of the patients with anaplastic. Yeah, so those are coming online. And so hopefully we'll have more to offer patients that don't have the BRAF mutation or don't have the rare fusions. But right now, what we do is lenvatinib pembrolizumab for the most part, because we just don't have, a better targeted therapy at the moment. But it's coming. It's coming. Yes. And we're really hopeful that it's going to work for the RAS mutated patients because we really need something for them. For now, the one that's open right now that we have is combined with a MEK inhibitor. We don't know about there's another trial that's being designed, and we don't know if it's going to be with a MEK inhibitor or not. Hopefully it will be, but it adds toxicity, skin toxicity. It's pretty bad. And then the next step is, if that works, then, removing the tumors, right? And then if that works, then, can we add immunotherapy? So we have to build, right? So we have to do baby steps first, right? We do the real targeted therapy for RAS, and then we start adding on to these things. That's how we did it with the BRAF.
And like Dr. Cabanillas said, some of these things, they look really good in a petri dish against cancer cells or in animal models, and then you get them into people and it's either not as effective, or sometimes the toxicities. There's some things that have come out that the toxicities are so bad that, it's kind of almost worse than, it's as bad as kind of having the cancer with those terrible toxicities. So I think that, those are kind of some other, and again, I do believe in the future, these what's called cellular-based therapies might be helpful, which are these CAR T cells or natural killer cells that are these CAR cells that they basically take your own T cells, grow them up, engineer them to attack your tumor. And they'll in bloodborne cancers, they're working pretty well. But I don't think they're quite there yet in solid tumors, but there's research being done in that area as well.
All those people on those waterfall plots that get to full, whatever it's called, remission, or when there's no evidence of disease.
Complete response. Yep.
Complete response.
Yep.
What happens to them? And do you have people who are on no treatment and have previously had anaplastic thyroid cancer? Because I'm sitting next to one.
I don't.
Yeah, he hasn't had
the
any
people who are
treatment
not
for
on
3
any
years.
therapy at all, who have no remission, no recurrence whatsoever. I don't.
3 years.
Localized is it just in the neck, or like distant metastatic disease? Not distant.
Oh, but it was
so
localized in the neck?
in the neck.
So
Yeah.
yes, with neck, we have seen that. Because again, especially if you can shrink it and get a good surgery and get everything out. There are people who go, patients who've got a long time.
Yeah, with the radiation though, and chemotherapy, we can get those. We now have a trial for patients like this where they had the radiation, they finished the radiation, and then we treat them for a year with immunotherapy, because about 75% of patients are going to end up with metastatic disease after the radiation to the neck. And so we want to prevent that, right? It's a very high risk disease. But that's fantastic if you've, not needed any of that.
Yeah, that's great.
Yeah, I just feel like we're sitting on a time bomb because we're doing absolutely nothing than monitoring. So I wondered what happens to those people with nothing.
Well, we don't have enough of them yet, but like I said, with a study like Dr. Cabanillas is doing, is because it is in other cancers as well. Once again, that's called adjuvant therapy. So you think you got it all out, and then you give something like an immunotherapy or some combination. They do this in a lot of other cancers where you give a combination of therapy for a set period of time, and even sometimes multiple sets. I think probably in the future, we'll be doing maybe more of that in somebody with what's called stage 2B disease. I don't know about stage 4B disease. I don't know about stage 4A, but those types of diseases where you think, I think we got it all, but we know the recurrence rate is very, very high and they come roaring back in people when they do. But there are some patients who especially have it localized, and got the therapy. I do have some of those patients who are not on anything and have not had a recurrence.
So what should we be doing?
Keep watching carefully. Keep watching carefully. Go, because I don't think your study would accept somebody 3 years out.
No, not 3 years out. This is like, a month or two out is what we accept on the trial. Yeah. But you've made it 3 years and that's pretty good. So I agree. Good. Keep watching.
Yeah. You got two opinions. Luckily they agreed. Well, if there's not anything else, I think we're good. Okay.
Well, yeah, I just wanted, I don't know. We just wanted to have all the ATC patients stand up, our survivors, so we can applaud you because you guys are just amazing. Look at this room. It used to be one, maybe two patients in these meetings.
Family members and one or two patients.
Yeah, that's amazing. It's been a wild ride.
Great. Well, thank you, everybody. And thank you for coming.